When Dr. Ekanayaka invited me for this unexpected talk, it had two purposes, one being as a fill-in talk, but there was a hidden agenda. So I tried to highlight a couple of simple cardiology principles through two cases, pretty simple facts, but I learned from them. Why simple, why complex? Because I felt that most of us, deliberately so, lead pretty complex and complicated lives. And although I live abroad, simplicity comes to my mind, and this is one of the pictures immediately come to my mind, walking down a field where there is no sounds. And but life is not that simple, but we can maybe. Steve Jobs, the founder of Apple, the inventor, the visionary of iPod and iPad and Apple Macintosh, once mentioned, the simple can be harder than the complex. You have to work hard to think clean to make it simple. But before Steve Jobs, even 2,600 years ago, this was known very well in the Eastern philosophy. Confucius said the same thing, that life is pretty simple, but we insist on making it complicated. So let's see whether these two cases had some hidden simplicity, but we try to work hard to make it difficult. So this is a tale of two exercising men. Patient one is an acquaintance of mine, a Sri Lankan, 54-year-old male, exercises regularly, pretty fanatically. He's a non-smoker. Everything is done well. He's normotensive, non-diabetic, normal cholesterol. His brother had a bypass surgery at the age of 44, and one day he calls and say, in Sinhalese, he's mentioned that very diminutive terms that in the peak exercise, he get a fleeting chest discomfort, which almost I dismissed as an electrophysiologist, pardon me. Then, something struck and I said, okay, he was living quite long ways from me, and I said, go to a nearby reputed facility and get a stress test. And then he mailed me this report, and I'm going to show you a few EKGs from that stress test and what I received. So this is his baseline ECG. His heartbeat was 45, and illustrating he was pretty athletic. Blood pressure was, maybe he was a little anxious, but his normal blood pressure is in the 120s. To me, it was unremarkable, and I have to have a disclaimer here in lead 3 at the very bottom to the left. You will see a T-wave inversions. In fact, I came to know that this was a lead misplacement, which was corrected. So pretty much at baseline, he's an unremarkable EKG. And then he went on the standard Bruce protocol and stage 3. And you have to make notice of this. This is what I noticed. So, even being an electrophysiologist, I see ST segmental upsloping kind of changes mostly in lead 2. They are maybe in V4, I sometimes wonder the horizontal ST depressions, but mostly upsloping. And I myself once ran on a treadmill, and I had the similar ST changes and finally dismissed as the upsloping. And so maybe that's stage 3, and he has an appropriate heart rate response. The blood pressure goes up appropriately. And he goes to stage 4. Do you see what do you see? I mean, you can take a look at by yourselves. You may see things that I don't see. Now I see pretty horizontal deep depressions, right? Everybody agrees? And you can pick and choose a lead, the lead V4 or lead 3 or AVF. I mean, pretty significant ST depressions down there. Anything else? I don't know. I mean, it's quite obvious to me. Wonderful. So I'm preaching to the choir here. So this is recovery. And in recovery, you see the ST segmental depressions persisting, and so I look at that. And I knew what you are talking about, but I dismissed that. So this is recovery into 3 minutes, where he has very deeply inverted T waves in the inferior leads. And this is the stress test report. And then 13 minutes into recovery, his ECG normalized. And this is the report I received. And that stress test was stopped due to chest pain. But the patient did experience chest pain during exercise. His heart rate response was appropriate, the normal blood pressure response, and good aerobic capacity. ECG-wise, there was greater than 2 millimeter ST segmental depressions, and 2 minutes into recovery, ST depression converted into very deep T waves, which persisted for 9 minutes and before reverting to baseline. So basically, this is what was mentioned. ST segment depression. So can you locate the lesion? Tricky question, right? You can. That's what I understand. Yeah, not based upon the ST depressions because they don't localize traditionally, but wonderful. I mean, why do I give this talk? Wonderful, yes. There was an ST segmental elevation. And indeed, that was the turning point. And why, what do you see there? Because ST segmental elevation always point towards the lesion and not the depression. So the reason I was trying to highlight is that this particular type of ST segment elevation is often ignored. Everybody picks up frontal or lateral or inferior ST elevations. But ST elevation in AVR is almost, except for in the illuminated view, is ignored. And more highlighting the fact here is that the ST elevation in AVR, which looks at the heart from the right shoulder downwards toward the mostly toward the right ventricle outflow tract and the basal septum. And it's ignored because we tend to believe that that lead gives reciprocal information compared to what is down here, AVL, AVF and 2 and 3. So here the highlighting fact is that AVR has a greater ST elevation compared to V1. Because if you think in anatomical terms, so the lesion was here as guessed. And it was not a total occlusion, but pretty significant ST. I mean, his right coronary was clean, and so was LV function at baseline. But this was not a total occlusion, but probably at peak exercise, it serves as a functional total occlusion. And I don't know whether there was an additional spasm came on top of it, but regardless, the practicality-wise, this was a left main occlusion. And so the point being that when you have a lead looking down on the heart and AVR looks at the most proximal part of the top part of the septum, and if you have a LAD lesion, a proximal LAD lesion, the EKG pattern is a little different. So this was actually first highlighted when I was in fellowship. I recall this article coming up, and I actually remember this, and from a group in Japan, and they are the first people to describe this. So it's not so long ago, and they only had about 15 patients or so to say the prediction of acute left main obstruction. Now this was not acute, but I think it was made acute during the intensity of stress test, and ST segmental elevation in AVR with less elevation in lead V1. And this was the comparison they made. If you look at to the left, here is the left main, and compared to the LAD and RCA in the limb leads, and here you have the precordial leads. So in left main lesion, the AVR contains an ST elevation which is greater than in the V1. This was maybe not a great example they presented, but in LAD, what you have is far greater ST elevation through the precordial leads, and which is less so in AVR. Because the LAD lesion is distal to left main and looks into not the basal septum but beyond. And of course, with RCA, you see the inferior ST elevation. So that was how it was differentiated. And this has a sensitivity, a specificity, and a positive predictive value of about 80%. So that was my first case. I think felt like a punishment for the young man who was exercising very well. But patient 2 was another patient. This is I'm going to highlight a simple fact. And again, the previous point was that for those who illuminated, it was pretty simple, but those who were not illuminated on that simple fact, it was a long, sought process to find where the lesion was. So the patient 2 was actually a 23-year-old ambulance technician, and this guy is he exercises routinely, another fanatic. And one day, and it's part of his job requires he maintains a certain physical activity profile. So he was at work, there was no call, so he did some push-ups and sit-ups while waiting for the emergency calls. And 5 minutes into exercise, he felt a little, heartbeat sensation, which can happen to anybody. So then he started feeling weak and got lightheaded. So he just managed to walk to the ambulance, and what he did was he sat down and hooked him to the defibrillator monitor, And then he looked at it, and his symptoms he got progressively weak. So he saw his heart rhythm on the monitor, and then he fainted. So this is the ambulance technician. So then he woke up a few seconds later, and he found some of the leads of the EKG fell off. He didn't have any other symptoms, even no chest pain, shortness of breath, no headaches. He didn't have any urinary or fecal incontinence or any weakness. But he was sweaty, and he was exhausted. So he went to bed and slept for a couple of hours. And then he got a call to pick up a patient. So he picked up the patient, he drove, came back to the ER with the patient. And then he talked to the emergency room doctor and showed, I had a little faintish spell. This is my EKG. How often you have a patient comes with the EKG and show, right? So, and the emergency room doctor got panicked and he was transferred to me. And this was the EKG. Oh, whatever that, you can see that in the bottom, the one lead had fallen off. So what do you see there? You see a progressive bradycardia, right? Pretty much so, and then ultimately leading to a pause. I don't know how long. Maybe the last, here it's a sinus bradycardia, and ultimately at the very end, I don't know whether it's an artifact or not, but this is certainly greater than 10 seconds, so on. So now I have a young guy, pretty active, with a prolonged bradycardia and a syncope. And on top of it, he's driving ambulance. And he has a pilot's license. You may ask why. Well, he's like a voluntary Air Force guy. So maintenance of that license requires pretty strong recommendations from me. Anything to suggest that he has heart disease, he will lose his job, plus everything. What's the differential diagnosis? Vasovagal. Very simple. That's what I felt. What made you to feel it's vasovagal?
Because it's sinus followed by a blood course. That can happen, and once you get the blood, then it recovers.
Yeah, there was a progressive sense of bradycardia. That's a vagal thing. If it's a sinus node dysfunction, now you don't expect sinus node dysfunction in a 23-year-old male. Very unlikely, unless he has some extremely rare channelopathy or something like that. So this could be vasovagal. And also the fact is that you see progressive bradycardia. When your vagal tone increases, usually what you get is you get brady, and then slow down and you faint. Or your blood pressure starts creeping down and you faint. So the progressiveness, it sounds like vasovagal. And it's the most likely scenario, because if this happened during exercise, otherwise I will be very worried about this guy. A young guy passing out during exercise is an ominous sign otherwise. Fortunately for him, he had the EKG. Otherwise, I'll be number one worried about what? Forget about EKG. What was the differential diagnosis without the EKG? What is the thing you want to exclude first? What's that? VT in terms of commonest cause of syncope during exercise. Yeah, there's catecholaminergic polymorphic VT, hypertrophic cardiomyopathy, anomalous coronary arteries. How many things you can think of? Brugada maybe, I don't know. Brugada usually during sleep, not exercise. Sometimes, and if it's a swimming type of exercise, long QT. And a lot of things you can think of, but those are very bad things. And this is during exercise, but fortunately he had the EKG, so I could think, okay, this is vagal. And so the ECG helped me to differentiate. Otherwise, he will be open for a gazillion tests to exclude all these things. So tentative diagnosis was vasovagal. Does he have indication for permanent pacemaker?
I think yes, because of his job.
See, that's the issue. If it's a first time, so if it's a vagal, you don't do anything, right? You just reassure the patient, drink a lot of fluids and all these things and say, although he had a 15-second pause, now that's something you have to bear the responsibility. Next time, if it happened during seated, and that's what worried me. Usually vasovagal doesn't have, well, it happened during exercise, sorry. Vasovagal, the typical vasovagal doesn't happen during exercise. So that was the thing. He had brady, and that was the argument against vasovagal. He was not just standing for a long time, then that could be vasovagal. So there were things up there. Obviously, nobody is going to put a pacemaker in this patient, but then what is it? So what is the simplest thing to do here? Most of the time we started complicated. I thought of, after a while, getting more history. Okay? So, who recognizes his character? Sherlock Holmes say that, it seemed to me that careful examination of the room and the lawn might possibly reveal some traces of this mysterious individual. You know my methods, Dr. Watson? There was none of them which I didn't apply to this inquiry. At the end of my inquiry, I discovered traces that were different from those which I expected. So, more information. So I tried to ask him questions. He had no medical history, no previous hospitalizations, not on any medicines, doesn't take any recreational drugs, no family history of syncope, sudden cardiac death. Physical exam, unremarkable, heart, lungs, no murmurs, nothing. Labs, so unremarkable, ECG, these are basic things, and echoes. So nothing was there. Then I asked, anything? You mentioned your heart was, had palpitations a little bit prior to. He said, I had a little bit. Since childhood, few seconds here and there. But nothing there. I never passed out before. So now I have this guy with a responsibility. You have a pilot, ambulance driver. Can I dismiss him and say, come back next time when you pass out? Probably not. And then he might lose his license. So what are these palpitations? Can you have vasovagal with palpitations? Yes, you can. You can. And that's the thing finally dawned a clue to me. How can palpitations or a tachycardia can cause vasovagal? Well, so I had a working hypothesis. Either it's a primary vasovagal with a significant bradycardia or a secondary vasovagal related to an arrhythmia. Just based on his history. There was nothing else there. And what happens during vasovagal is, this is a very simplified way to say that you pull the blood in the leg suddenly and it activates your sympathetic system. This is old physiology I learned many years ago. And that sympathetic activation causes maybe the part of the left ventricle to contract vigorously. And when it contracts vigorously, those impulses go through these C fibers to the brainstem, to the cardiac center and so on, and the brainstem perceives that the heart is beating strong, pretty inotropic. So the reflex-wise, it tries to, drop the blood pressure. Contrary to what it should do, because the venous pooling actually causes hypotension, but then it causes sympathetic activation. Sympathetic activation causes, increased contractility to the heart, and then thereby the afferent fibers to the brainstem misreads it, and then causes reflex bradycardia or hypotension. So that's vasovagal reflex in a very simplified term, very simplified way. And the classical vasovagal, let's say I'm standing on a tilt table or something like that. The moment I stand up, you can see here at the top heart rate, at the bottom the blood pressure. The moment we stand up, the heart rate goes up compensatory wise a little bit, and then it stays stable. Blood pressure might drop a little bit upon assuming supine posture, but then it remains stable. Then after a while, when the pooling gets more and more, the reflex kicks in, and then you get brady or hypotensive. At one moment, you can't maintain your cerebral perfusion and you faint. So that's a classical vasovagal. And usually the vasovagal syncope progresses, you see more with aging, So this is a differentiation between male and female, and the females, young ladies and girls tend to have a peak there, but beyond that, rest sort of you have more vasovagal risk due with aging. The age of onset vasovagal syncope usually you see in a younger age group or over 70 years. So that's the classical vasovagal. But this one, I thought this young man, what kind of arrhythmia he should have? Most likely maybe he has an SVT, I don't know. But it's worthwhile looking into because of his profession. So I looked into the literature, what's in there. There's not much done. And there was this article in 2001 I picked up. And in this particular series done in Europe, they studied patients with supraventricular tachycardia, and in that series, they found 18% of them had some sort of a vasovagal type reaction. Now that I thought a large, too disproportionately large, but that was what they reported. But what they mentioned was that if you have supraventricular tachycardia, you may have it for many years without any accompanying symptoms, but later on you might get a vagal attack. So there's no consistency with each episode it's associated with or not. So that's something you need to know, because that's what I tell my patients, that maybe all these years you had palpitations and you were fine, and so then you learn to live with it and try to take more and more risks with it, but it doesn't give you any sort of a guarantee that the next episode might end up in a car crash if you get it during palpitations. So, and so also, particularly in these young people, whether they have SVT, they may not even know it. So in this scenario, he didn't know much about it. So how do you get syncope with tachycardia? I think the first thing that comes to mind is heart is beating so fast, it doesn't fill, so you drop your blood pressure, which is true. Poor cardiac filling is one reason. But at the same time, you may have a reflex event going on when you're on tachycardia, and that's what I was alluding to here, the secondary vasovagal. And there's another version. Let's say somebody who's elderly has sort of a sinus node dysfunction underlying, and you are in a tachycardia for a prolonged period of time. What's the tachycardia I'm talking about in elderly? Atrial fibrillation. So you're in atrial fibrillation long period of time and suddenly terminates. And the sinus node is sleeping. It's sleeping. And it takes a while to wake up. So from the termination until the next sinus beat, you have a long pause, which is long enough for somebody to faint. So that's a sinus node dysfunction, particularly in the elderly. And there's another version where you can pass out with SVT, and that is how, like if you have an additional pathway, like an accessory pathway, which can conduct very fast. So suddenly it can conduct down the pathway very fast. So atrial fibrillation will go down the pathway to the ventricle faster than AV node. By doing so, a fib will be converted to ventricular fibrillation, and you can die from it. So those are the way SVT can syncope mechanistically associated, and these are a few ECG examples of what I was mentioning here. Here you have I'm pointing with the right. I don't want to use a laser on Dr. Ekenaika, but maybe I use it here. On the left of the screen, you see the SVT, and when it terminates, what you can see is it terminates and the patient gets brady and brady. So this is sinus node dysfunction, example, conversion, AFib to with a pause. This is atrial flutter, terminates to with a pause. This is somebody with an accessory pathway. There's a delta wave, but when the patient goes to atrial fib, you can see how fast it goes, and sometimes between 2 beats, it can be 300 beats per minute, and this can easily convert to VFib, and the patient might get syncopal or even die. So I ended up doing an EP study on that patient. I'm almost done in 30 seconds. In the EP study, I induced an SVT, and what he had was an accessory pathway on the lateral side, which was ablated. And so far, he has not had any syncope after this. So basically, it was a diagnosis by exclusion. When you have eliminated the impossible, whatever remains, however improbable, must be the truth. So with that, What did I learn? When you read the ECGs, particularly actively look at AVR. And when assessing a patient with syncope, a detailed history is more important than any other component of the assessment. Pretty simple, right? So, thank you.